everyone, today we're going to talk about screening programs. I'm Geraldine Cambron, your course instructor. So let's talk about one of these screening tests. Let's talk about fasting blood sugar. The way this works is a person is asked to fast, usually overnight, and when they come in the morning, the lab tech usually pricks their finger and a very small amount of blood is used on the test strip, which is inserted into this little machine called a glucometer, and it tests a person's blood sugar levels. And from that measure, it can be determined if this person screens as healthy normal, prediabetes, or diabetes. And based on that screen, a person would then possibly go in for further diagnostic testing if they're in prediabetes or the diabetes level. But as I've said before, we always have to consider how are these different outcomes tested, and is there any variability due to different factors? And so we can't always accept the results at face value. We have to think about, are there any characteristics that might affect fasting blood sugar? Such as, let's see, if somebody, let's say, made their lunch and still had something that was sweet on their fingertips, that might cause an increase in their fasting blood sugar. If they worked out very hard in the morning, they're training for a marathon, and then they come in, that might affect their fasting blood sugar. If they woke up in the middle of the night and had a little snack and just didn't want to tell anybody, yes, I did eat with, when I was supposed to be fasting, that might affect their blood sugar. And even if the meter itself isn't calibrated correctly, that might affect it. And so please always keep in mind that when we get back screening tests, results, they're not always accurate, or even the diagnostic tests are not always accurate because there's so many different factors that might affect it. I just want to say one more thing about that, and that is the difference between reliability and validity. If something is reliable, the same thing happens over and over. And so if we say a friend is reliable, we know that they'll always be there for us because they are over and over. So with tests, reliability is a factor of, does the meter give us the same reading over and over? But we also have to look at validity. Is something valid? Is it true? Is it accurate? Is it real? So even if we get the same measure over and over and something is very reliable, it may not be valid. It may be off the mark. Maybe it's not calibrated accurately. And so we have to always keep that in mind as well. Was the instrumentation calibrated appropriately? Let's pretend, let's think that we have real results. They're accurate, and these are the results that we get. We then can put them into these different categories. So blood sugar is on a continuous scale, but we can put it in an ordinal scale of normal, pre-diabetic, and diabetic. Or we can put it into a dichotomous variable as pre-diabetic yes or pre-diabetic no. And so this is the way that screening tests frequently work. People don't always want to know, well, what's my number? They want to know, is it good or bad? Am I okay or not? Should I go for further testing or not? And so in this category, when we look at pre-diabetic, we see that pre-diabetic is in the range of about 101 to 125. Okay, but it didn't take much searching on the internet to find a different one that says prediabetes is 110 to 125. And so what I'm trying to show you is that these ranges can vary from place to place, and this is true for other tests as well. And so we have to keep in mind that when we are put in a category, sometimes it's worthwhile to look at what is the range provided for that category, and is it what we expected it to be? So something that I do want to point out is I got this from a friend, and what this is on the top, it's a distribution, bell curve distribution of people without diabetes. And so these are the number of cases who have, and we see across the bottom, the blood sugar levels that spanned from not quite 40, so maybe 50, all the way up to not quite 200. These are all people without diabetes. And so when we look at the previous slide where it says here are the ranges for people who are normal, people who have prediabetes, and people who have diabetes, at least are screening for that, people can fall outside those ranges and still be okay. Or they might fall within those ranges, such as in the chart below. These are people who have diabetes. They can fall in the normal range, but they actually have diabetes. And so sometimes there's crossover. So we just have to, again, keep in mind that even though we're using these screening tests to help make determinations as to whether or not people need to go for further diagnostic testing, that there's a lot of variables that are involved when we're looking at the results. So it's not just a simple yes or no. Sometimes it's based on the cut point or the way the test was done, or things like that. So we're not going to actually go over sensitivity and specificity in this video, but what I do want to say is that when sensitivity and specificity are calculated, it really matters where that cut point is. So if we have the cut point for prediabetes at 110 through 125, our test score on the left-hand side, those who test positive, there's going to be more people who test positive, versus if we end up using the cut score for prediabetes of 115 to 125 or 110 to 125. Now there's going to be fewer people who have the test score positive. And what that's going to do is shrink down the true positive and the false positive. And so just take a look at this chart and think about, if we move the cut point on any of these screening tests to determine whether or not it's normal or abnormal, how does that affect the sensitivity and specificity? And sometimes it's intentionally moved in one direction or the other based on what what is needed for that type of screening test. So when we look at screening tests, we have to consider that there are risks involved. If we have a true positive, that means that the patient was screened, got a positive test, went through diagnostic testing, and ended up finding out that they truly do have the disease. So there might not be any risk involved with that. But we really have to think about it. If there's no effective treatment, is it really even worthwhile finding out ahead of time that the disease is present? And if the disease is present and the person finds out in a screening test, will that change anything about their lifestyle, such as their social standing? If word gets out that they have this disease, will that affect them? Or health coverage, or medical care, or where they can get medical care? Will any of those things be affected? If it's a false positive, that means that the screen shows up as positive, but it's not true. So now they go through all this testing. It's probably expensive, but perhaps sometimes even worse, it's anxiety provoking. It's very fearful. People think that they might have this disease and come to find out they don't. And so this happens a lot with mammography, where women go in, they get tested, they have a positive test, and it turns out to be false. And so this causes some women to not want to ever get another mammogram. So there's true negatives, which is wonderful. What this means is that the screening test said, no, you don't have this disease, and it turns out truly you don't have the disease. Well, if there's a lot of people who have that, is it really worthwhile having that type of screening test? Is it a needless cost? Or should the physicians wait and not do screening tests, but wait until people demonstrate clinical symptoms before they actually start looking to determine do they have this diagnosis or not. And then finally, the last one that is sometimes the most disheartening, which is the false negative. This is when a screening test reads negative and it's wrong. And so a person goes around thinking, I don't have that disease, when they actually might, or do, I should say. And so they might not pay attention to any early symptoms. They might not go in to talk to their doctor about something that's going on. They might not, seek further care. And that just delays intervention, which might ultimately affect their course of the disease. So let's, as the last thing we focus on, take a look at the course of the disease. So we've talked about natural history before of a disease. And in this chart, we have subclinical or preclinical disease. So once a person starts having changes, but they don't have any symptoms, that's all preclinical or subclinical. Once they have symptoms, they usually then go in, get tested, and they get diagnosed, and now we are moving into clinical disease. With screening tests, those are done during the subclinical portion of this. And what happens is that time of diagnosis gets moved back. And sometimes that's a wonderful thing, because if people can get treatment early, early intervention can save people. And that's a wonderful thing, because if people go through treatment with stage 1 versus stage 4, they have a higher risk of, or a higher possibility of survival. But sometimes what happens is something called lead time bias. This is when a screening test makes it look like it's better, but it's not really. And so in this example, we see without the screen, people, this is just an example, people with a certain type of cancer are typically diagnosed around the age of 67. They then on average pass 3 years later at age 70, which looks like a 5-year survival rate of 0%. Survival rates are very common when we look at cancer studies, and so within that 5 years, or at the end of that 5 years, in this example, nobody survived. With the screen, the cancer is diagnosed much earlier. So it's diagnosed 7 years earlier at age 60 on average. And now it looks like these folks, oh wow, they lived 10 years instead of just 3 years. And they also died at age 70. Now we have a 5-year survival rate of 100%, and this looks amazing. What a wonderful screening test that we have here. But is it? If people are dying at the same age on average, and yet they're going through longer periods of treatment, is it really worth it? Is the screening worth it to find out that they have this disease that much earlier just for them to live the same amount of time? Now, we hope that screening tests aren't like this. We do hope that they do extend life or maybe even cure people, which is the point of screening tests, but there is sometimes this lead time bias, and it needs to be looked into. So if you have any questions about this, please let me know. Thank you.